Good morning, everybody. It's a pleasure to be among all of you today, this morning. And I also have the pleasure of introducing Dr. Sobcyzk. Dr. Sobcyzk grew up in Omaha, Nebraska, and attended the medical school at the University of Nebraska Medical Center. He also completed his pediatric residency and along with a one-year fellowship in cardiovascular pathology. He then came to the Children's Hospital Medical Center in Cincinnati, Ohio, and completed his 3-year fellowship in pediatric cardiology. And then he moved on to join as faculty at University of Louisville in 1990. Dr. Sobcyzk has had an amazing career. He's very well published, and among the highlights, several highlights, a few notable ones that I'm going to say today. He directed the echocardiography lab and led to development of the nation's first trans-telephonic echocardiographic network as part of university's statewide outreach program, which has been extremely successful. Since 2011, he has also directed the adult congenital heart program, both at the University of Louisville and Norton Healthcare. Again, it's an absolute pleasure to introduce and welcome Dr. Sobcyzk among ourselves.
Well, good morning, everybody, and thank you for attending this year's virtual meeting. And for those of you who haven't seen our downtown new bridging, here is a nice virtual view of me sitting on our walking bridge looking out over the skyline of Louisville. So the title of my talk is Navigating the Rising Tide of Adult Congenital Heart Disease, or when you need to swim on your own and when to call for a life raft. I have no conflicts for today's presentation. And when you think of a tide, you think of something that moves slowly and is manageable and can be handled with quite a lot of comfort. But that's not really what this title of this talk might otherwise be. It might more aptly be called the oncoming tidal wave of adult congenital heart disease. And this tidal wave is 50 years in the making, and it's now coming on shore for all of us to manage. So how we're going to do this today is I want to talk about the basic landscape of the world of adult congenital heart disease as it is here in 2020. What is the baseline of congenital heart disease and how that's been changing over time, and when will this change stop and how will it stop? After that, we'll talk a little bit more about how we can handle it, what can we do to take care of it, what have been some of the recent developments in the management of adults with congenital heart disease to help us cope with these changing demographics in this patient population. So first, what's the baseline of these things and how are they changing and when will they stop? If you look at the overall prevalence of congenital heart disease in the population is about 1 in 100 or 9 in 1,000. About 1.2 million babies are born every year worldwide with congenital heart disease, and it's about 36,000 a year in the United States alone. In the current era, 90% of these patients will reach adulthood. That's 20,000 new patients every year. And there are currently estimated to be 1.5 million adults with congenital heart disease living in the US. And since 2005, the number of patients who are adults with congenital heart disease have outnumbered patients who are pediatric age group with congenital heart disease. So if you look at the basic population of the types of congenital heart disease, only the very simplest of shunt lesions, if properly and completely repaired, do not really require much ongoing care and intervention. And we can expect this group of patients to have an equivalent risk for cardiac problems or other problems with the basic population. The rest of these lesions, starting with atrioventricular canal defects, all of this, the stenotic defects, and of course, all of this complex cyanotic defects, all of these lesions we now know have ongoing lifetime issues and need some form of ongoing lifetime congenital heart disease care. To expand a little bit on how we got there over time, again, starting with the basic incidence of about 1 in 100, we've developed over the last several decades the ability to make early diagnoses with things like echocardiography, fetal diagnoses. We've improved our surgical techniques. We've had earlier and earlier repairs and advances in postoperative ICU care. This, of course, has resulted in improved perioperative mortality. More patients survive their operations. That leads to better midterm survival. If you get out of the hospital, there's a good chance you're going to make it for multiple years and perhaps even into your teens. And then more recently, we've had ongoing improvement in outpatient management, non-invasive procedures, catheter-based therapies, that have allowed us to have this ever-expanding population of patients with congenital heart disease who enter into adulthood. If you want to look at just the complex patients and thinking about how these innovations have resulted in improvement, if you were born in 1940, you had really only, your outcome was based on the natural history of your disease. And then in the 40s, the Blalock-Taussig shunt was done for patients who had some form of severe pulmonary stenosis, or we developed the pulmonary artery band that might decrease the shunt flow in shunt lesions such as VSD. So going in, if you were born in 1960, in addition to these conditions, we developed cardiopulmonary bypass and we developed a balloon atrial septostomy techniques that allowed us to take care of the patients with transposition with the procedures known as the mustard or Senning atrial switch or atrial redirection operations. And again, so going from about 15% of patients making it to 18, we moved still, but not to 20%. In the 1970s, we continued to build on the surgical outcomes of these prior procedures and these prior innovations, but we started to develop the ability to do complex operations on patients with more complex conditions such as tricuspid atresia with the Fontan operation, which reroutes the systemic venous flow directly into the pulmonary arteries. And again, the addition of all these innovations allowed about 40 to 45% of patients born in 1970 to reach adulthood. In 1980, we added additional skill sets and additional technical improvements that allowed us to operate on the most complex hearts, which resulted in us being able to do a Norwood operation or heart transplantation in neonates with babies with hypoplastic left heart syndrome, and the procedure called a bidirectional gland, which is part of what we now do as the Fontan operation, has allowed the survival of these patients with complex single ventricles to the point where combining all of these innovations over the last 70, 75 years have led us to 80% survival. That's if you're born in 1980. And again, if you're born in the year 2000 and beyond, we expect 90+% of these patients to reach adulthood. And so this growing population kind of seemed to have caught us a little bit by surprise as pediatric cardiologists, because a familiar conversation that I had with my patients and was probably true of pediatric cardiologists senior to me would be the patients would begin to ask or think, why does my pediatric cardiologist keep telling me or my parents that they didn't expect me to live this long and we weren't quite sure what to do with you if you started to have new problems? Another question that might be asked, why does my pediatric cardiologist keep sending me away to Boston or to UCLA or to Houston or to Mayo Clinic for my career, or for my care rather? Well, during the latter part of the last century, centers in Boston and UCLA, the Mayo Clinic and Baylor developed physicians who had special interest in adults with congenital heart disease. Some textbooks were written, people were trained or worked just in the area of adults with congenital heart disease, but it wasn't a formalized sort of thing. And there were just a few centers where people would look to have specialized care when, of course, their primary cardiologists sort of reached the end of their abilities. And so the last question is, why can't my doctor get better at this job? And so this was sort of the beginning of this tidal wave of interest and the push for higher levels of care with adults with congenital heart disease. So these groups of people didn't take these issues sitting down or lying down. And in 1998, patients and families organized to form the Adult Congenital Heart Association, and they were dedicated to support individuals and families advancing care and treatment available in their own communities or in the community as a whole. These are quotes directly off the website of this organization. Their mission is to improve the extent of the lives of millions of people born with heart defects through education, advocacy, and research. And it did not take long for these individuals to push their agenda and push their mission for education and research. And within 2 years, with the advocacy of these folks, the 32nd Bethesda Conference for Adult Congenital Heart Disease began the process of looking more deeply into what is required, what should be the organization of management of these patients as they get older. And then they started out building a concept that we use today in terms of grouping lesions in terms of their complexity and the expectations of their outcomes and complications. And so they started out with a group of simple lesions, moderately severe lesions, and complex lesions listed here. We'll come back to this grouping throughout the rest of the talk. And so with that impetus in 2000, research and papers began to be published that sort of explored exactly what the population looks like, what their problems are, what are their needs going forward. And so prior to this time, there was only a guesswork that how many patients had congenital heart disease, how many adults had this condition versus kids. And again, publications in the early 2000s began to see clearly that more adults had congenital heart disease than might have been expected unless you looked more carefully into the actual databases of multiple centers across the country and across the world. Looking more carefully at what kind of patients are still alive in adulthood, obviously the simple lesions had a high survival rate, but even the more complex patients, by the time we got to year 2006, it was clear that there were hundreds of thousands of these patients with congenital heart disease who had complex lesions as opposed to kids. And when you put the whole total, by 2006, there were almost 1 million adults with congenital heart disease, and that was 10 years ago. We know now that that population exceeds 1.5 million. And since this paper was published, we see that this group of patients is expanding by 5% a year. When you look worldwide, this is some data from 2015, shows that the population, particularly in Western countries, continues to grow as the number and proportion of adults outstrip the proportion in children, although that's not necessarily true in some of the less developed countries or regions of the world, but the population of adults in all parts of the world, those with congenital heart disease, is growing and remains very large and will only get larger. Looking again at some additional data about the age of these patients. These are patients with considered severe congenital heart disease, and again, published in 2015, looking at data from 2010. The average age of the patient with severe congenital heart disease in 2010 was 25 years of age. And that again was in 2010. We know with the rapid rate and the survival that the average age is probably closer to the 35 or 36 years. And these are patients with single ventricles, complex transposition, complex repairs of tetralogy of Fallot's, complex repairs of endocardial cushion defects. Again, looking at in some Canadian data, there shows that this is just the prevalence of the patients in their referral base. And again, for adults, 6 out of 1,000 patients in their population might have congenital heart disease and be postoperative. And 4 out of 1,000 geriatric patients have congenital heart disease and postoperative status. So it is very clear this population is large and growing. Some additional, more recent data coming out of Europe from Dr. Mulder and colleagues shows that just looking at the curve of expected survival and the growth, the curve is striking in terms of the number of patients and the volume of patients who are getting older and how this curve is changing from this concave curve to this curve. And this looks very much like a tidal wave forming, if anything does. How long will this last is another question that I said we would look at. So this was some recent publication by a health metrics group looking at what sort of resources would be needed by the healthcare industry and by governmental support societies and how to pay for this and what kind of resources will be utilized. And they anticipated that the population will grow at a steady rate before it equalizes in the year about 2060. So even now in 2020, we can expect the population of patients with of adults with congenital heart disease to continue to grow for the next 40 years. So that's well past my own time in my career and well into many young people's career. How long do these people live and what is their life expectancy? Estimated looking at Kaplan-Meier curve from that same circulation research paper from Europe, with the dotted line showing what the normal population Kaplan-Meier analysis for their survival. The simplest congenital heart disease almost tracks completely with the normal population, and only the most severe have a substantially different track. So even looking through this data, at age 60, you can expect 45% of your patients with severe congenital heart disease to be alive, and over 80% of those with moderate disease, and almost the same number as healthy individuals, those with mild conditions. And looking again in this paper at those, what do they die of? So of course you would expect many of them or most of them to die from their congenital heart disease. And so looking, about 2/3 of them do seem to die either from progressive heart failure, from a sudden cardiac death, presumably from an arrhythmia, other kinds of complications from their congenital heart disease, non-congenital heart disease vascular lesions, but almost 1/4 of them die from something other than their congenital heart disease. Not an insignificant number of patients survive all through their congenital heart disease and succumb to some other condition or accident. And of course, as most people know, the older you get, the more likely you are to have arrhythmia problems. This is true of the adult congenital population, although the population of patients falls there, the degree with which they have ongoing rhythm issues continues to rise, keeping all of my and our electrophysiology colleagues quite busy for years and years to come. So with the impetus and the pressure of the patients themselves and the Adult Congenital Heart Association and their medical colleagues, we've learned that those adults with congenital heart disease have long-term cardiovascular complications that we now think we have a better grasp of over the last 20 years. We know based on the last slide, that they have a high incidence of arrhythmias, both atrial and ventricular. This results in a higher risk of sudden cardiac death from their congenital heart disease and associated problems. They have ongoing residual vascular lesions and shunts, which put them at a higher risk of stroke. And they have either their native valves or their operative valves often have progressive disease, putting them at higher risk of valve dysfunction and endocarditis. And these things combined increases their risk of developing heart failure, both on the right side, the left side, and we see both systolic and diastolic dysfunction occurring, and they have a higher risk of developing pulmonary hypertension, particularly those patients who have a late repair, that being over 2 to 4 years of age, which is a large proportion of our patients, particularly the older ones, would be defined as having a late operative repair. We've also learned over the last 20 years that there's a large proportion of non-cardiovascular complications in adults with congenital heart disease. We know from other conditions and childhood illnesses that there's large social challenges for these patients. They have lifetime issues with insurability. They have lifetime limitations, often both in sports when they're children and work limitations as adults. They have a higher chance and risk of having learning disabilities and having attention deficit hyperactivity disorder and the concomitant difficulties that creates in adulthood. These social challenges that we know, again, from other chronic diseases of childhood, they have a lot of personal challenges of self-image, higher instances of depression, higher risk and instances of substance abuse. And then lastly, we know that the diseases of adulthood interact with their congenital heart disease and vice versa. So these comorbidities have become very important in monitoring adults with congenital heart disease, including hypertension, stroke, coronary disease, and smoking, sleep apnea, obesity, and on with adult comorbidities. So through the last couple of decades, the ACHA has worked with the medical community to develop both educational materials that are widely available on their website. I would urge everyone here to access their website, which has excellent materials, and this is among them. These are patient education materials about raising the patient's awareness that they have a need for lifetime care. And again, going back to the types of lesions that need care and how often they should be seen by cardiologists who specialize in congenital heart disease. And again, this material has been out by the ACHA for most of their existence and have been very helpful to patients and providers alike. They've partnered more specifically with the ACC to again have educational material available through alternate routes, including the provider action for treating congenital heart disease with educational brochures for both providers and patients. This is again highlighting the different kinds of lesions and the need for ongoing care. So to summarize the basic landscape of what we're looking at, it's clear that the population of patients with congenital heart disease is not only growing, it's evolving almost on a constant basis. We know now over the last 20 years with greater depth and detail the varied and multiple long-term complications that these patients suffer. And so any question about who or what patients are fixed or repaired, we know the answer to that question is no. Very few patients are actually cured or repaired of their disease. And so to quote, a famous movie regarding ocean-faring activities, we're going to need a bigger boat. There's a need for more than just the information that we've had. We have the community of adult care with congenital heart disease needed to expand in a more formal way. And so we talked about the landscape and what's going on, and now I wanted to talk about what in 2020 is available, what can both primary care providers and adult cardiologists do in facing this, and why it's very challenging for these folks here to face this alone. And again, driven a lot by the ACHA, new information is being made available, new support systems have been built, and new ways of managing these patients are rapidly being developed. And so one of the most important recent publications that has become sort of the Bible of us in the adult congenital heart disease world with the guidelines for management from 2018, published in early 2019, and widely available if you're a member of the ACC, as most everybody in this audience should be. Then this is available in multiple forms as a PDF. The slide set of which I'm sharing here coming up, some of the slides from this talk are the slide sets that are available to everyone. So I would encourage everybody to download this article as a reference. It is an enormous help to those of us who specialize in this, and certainly can be very helpful to those of you who might be seeing these patients for the first time. One of the important things that this particular document generated, and there was a previous document in the early 2000s, it wasn't nearly as organized or as helpful, but they've introduced the concept of an anatomic physiologic classification for these patients that help guide the degree to which we should follow them, helps to promote the thought process for how to assess and manage these patients. And so again, going back to the three types of lesions, they again have sort of refined what constitutes the simplest of lesions, and there aren't very many of those. Isolated little defects and very mild pulmonary stenosis, and only few of the repaired defects would be considered the class 1 or stage 1 simple defects. There's a larger proportion that are considered moderate complexity. And although they're listed here alphabetically, and again, this is very available on the website, what's worth pointing out is that every single type of left heart obstructive lesion is considered moderately complex and would warrant regular follow-up with an adult congenital heart disease specialist, including bicuspid aortic valves in the context of congenital aortic valve disease, mitral valve disease, coarctation, subvalvular aortic stenosis, excluding hypertrophic cardiomyopathy, and even even any form of supravalvular aortic stenosis. Maybe somewhat more surprising to be in the moderate category is right heart obstructive disease, including right ventricular outflow tract obstruction of the muscular type. Pulmonary valve regurgitation. This one should be starred. This has become a major source of patient complication over time. Progressive pulmonary valve regurgitation often leads to right heart failure, tricuspid regurgitation, and right ventricular based arrhythmias, either atrial arrhythmias or right ventricular based tachycardias. And then, of course, those of greater complexity, clearly those need regular care. So the anatomy has been organized in 3 terms. And then on top of this, they've established a 4-stage physiologic state based primarily on heart failure class symptoms, in addition to these other comorbidities in terms of hemodynamic sequela, rhythm problems, functional capacity, and whether there are other end organ difficulties. And of course, these follow along with New York Heart Association classification symptoms and progressive changes in these other parameters. They've stretched out these parameters so that, again, within the context of this publication, very detailed identification and quantification of what constitutes the degree of dysfunction within these classifications. And probably, maybe somewhat surprisingly, but maybe not, a lot of focus on keeping track of the important end organ dysfunction that we see in the renal system, the hepatic system, and the pulmonary system. This is a slammed together version of these stagings that's widely available in every spot in our office, so that those of us taking care of this keep track of these, and we try to identify our patients in our notes as to have these stages and to have this AP classification in our documentation. The publication that was meant to help us in terms of identifying the severity of their condition, even as it might relate to getting insurance approval for testing, et cetera. So it was a very well organized paper and a very well organized guideline to help us move forward. Of course, they went through this in the usual way that guidelines do, with class of recommendations and level of evidence. In this particular publication, again, it's provided specific recommendations for over 30 specific cardiovascular lesions, and in addition has provided additional information and guidance regarding important genetic syndromes, pregnancy guidelines, and recommendations, optimizing drug therapy, what works, what doesn't work, non-cardiac care, including non-cardiac surgery, what kind of congenital heart disease patients should have their gallbladder removed in a community hospital versus coming to a center that cares for patients with congenital heart disease. Recommendations for transplant, even for how to manage and prepare for palliative care for our patients who are end stage. Within the context of each of these 30 odd lesions, they would provide both diagnostic guidelines with the strength of the recommendation and the level of evidence, a large grouping of therapeutic options with great detail about what constitutes the plan of care for these patients. And for most, but not all of these lesions, they would give guidance as to the follow-up and testing intervals. Again, looking at an atrial septal defect, which would be a level 1, and then the physiologic stage, which very little problems may be being seen every 3 to 5 years. But those who might be a late repair or have residual needs may be seen as much as every 6 months, gives guidance as to how often it is appropriate to provide testing services and interventions. And in some of the lesions, they provide what's becoming standard in many, many guidelines is flow sheets and charts as to help us manage and move toward appropriate clinical decision making. So on top of, and I built at the same time of these guidelines, included the recommendations and the development of what I might in turn discern enhanced adult congenital heart disease care. 2 important things have happened in the last 5 years. The first of which is the board certification in adult congenital heart disease. This was instituted in 2015 with the first exam, and the exam occurs every other year on the odd numbers years, and it is a board certification through the American Board of Internal Medicine. It was a bit of a surprise and a bit of disappointment to some people, but the ABIM requires 2 years of fellowship training, whether you pass through what's called through the pediatric cardiology fellowship pathway. After completing that, you would then go back to and complete a 2-year fellowship at an approved fellowship program, or you could become an adult cardiology through a standard adult cardiology fellowship before going for a 2-year fellowship in order to be eligible for the boards. They did provide for a grandfather grace period for those of us who met a certain level of experience criteria. We did have to pay our membership dues to the ABIM, and me being a pediatrician, had to join up with the ABIM before I could qualify to take the exam. The grace period ended in 2019 with the examination in 2021 requiring all those who wish to sit for the exam to take the 2-year fellowship. And at this point in time, I'm aware of 3 of us who are the grandpas here in Kentucky. That would be myself, Dr. Juan Villafana, who many of you know, and Dr. Andy Leventhal, University of Kentucky. If there's anybody else who has passed the exam in the audience, my apologies. Certainly those who have grandfathered in. And the second enhanced ACHD care development that has occurred in the last 5 years is ACHD program accreditation. And this is, again, driven by and sponsored by the ACHA. And they have established guidelines for what is being called the comprehensive care centers for ACHD. This was instituted in 2016 with 11 initial centers qualifying and being announced in that year. And comprehensive is hardly the word. There are 19 service area requirements in order to be considered eligible to attain this accreditation. It starts with having primary care providers that meet the criteria for being an ACHD cardiologist, including board certification or eligibility, a medical director. You have to, nurse clinicians and advanced nurse practitioners or physician's assistants are a requirement to meet eligibility. On top of this, you must prove expertise in cardiovascular surgery in adults with congenital heart disease. Advanced therapies must be available within your system, including transplantation. You have to have experience, interventional cath and electrophysiology support for adults with congenital heart disease, as well as availability of management of pulmonary arterial hypertension. In addition to this, you have to demonstrate a high level of experience as well as capabilities in advanced imaging techniques, including echocardiography, MRI, CT, and exercise testing with rehabilitation. And lastly, and often most challenging, is a wide range of additional services. Inpatient and outpatient services include other medical subspecialties who are able to assist you in the complex interactions of folks with congenital heart disease, including having on board and signing on to see your patients that might include pulmonologists, endocrinologists, nephrologists, infectious disease specialists. And each department in your institution has to sign on and have a leadership mentor member within your assigned group in these areas. These areas include transitional services, patient-centered care, reproductive service, and everybody has to require to have the ability for social services and social work within the context of your service. As of this week, the ACHA states there are 34 accredited comprehensive care centers focused, however, on only 23 states. There are currently none completely certified in Kentucky, although UK and Cincinnati have an affiliation that provides the full complement of these services. Our own group at U of L and Norton Healthcare, our application was completed this year with a site visit looking for the fall with approval in 2021. Our own program will include a wide range of local community support, including all 9 of our outreach clinics with the capability to help manage adults with congenital heart disease. We have 29 tele-echo sites where imaging can be performed and transmitted prior to or at the time of visits. And we have established, with the help, unfortunately, better or for worse, with the COVID pandemic, have amped up our ability for daily telehealth visits that would include those with congenital heart disease who are adults. This is our current team that headed by myself as the director. Melissa Prota joined us a year or so ago from Stanford. She has completed her 2-year fellowship and will be sitting for the boards in the next session. We have 2 nurse practitioners, a nurse clinician, our cardiovascular director, and as a nurse navigator on our team. And we are available 24/7 to help with problems. So to summarize what to do, we know now that the recent guidelines have provided us with a framework to optimize care for adult congenital heart disease patients. We've seen that the development of the ACHD board certification and program accreditation enhances care, and there have been recent publications that show improved outcomes with centers who provide care who have all of these program accreditation guidelines met. And so the bottom line is no one needs to swim alone. The ACHD program leaders, both for us here at U of L, those at UK, and the Cincinnati team here in Kentucky are available 24/7, 365 to throw you a line. So bottom line, people often ask, who should I call? What should I worry about? And my answer is, if you have a patient who has a chest scar that they obtained as a child, please call. You don't even have to let them leave the office. Any question, there is no question too small, and sometimes the answer is surprising about what we need to do. The bottom line is we are here to provide the rescue. And so with that, I'll take any questions that anyone might have, and I thank you all for your attention.